So if you're an orthodontist and all you do is expansion, you're actually helping nasal volume. So you're helping airways whether you know it or not. Does that affect how that airway grows over time? Perhaps. From an orthodontic perspective, we have to think about the structures that involve us, which again, we're tooth focused, of course. But this paper, and Rebecca Bachau in her beautiful keynote yesterday mentioned this paper, the minor study. I'm going to break it down in super simple terms. Here's what this study did. It was a cone beam CT study. They looked at the coronal slice of the jaws at the first molars. And they divided the sample up into 5 categories. Normal control on the far left, unilateral crossbites, bilateral crossbites, superior convergent, which we don't know very much about in orthodontics, and then finally on the far right, inferior convergent, which I don't see very often. It's the superior convergent that's the tricky one for us. That's where the maxillary molars are leaning out towards the mandible and the mandibular molars are leaning in. Now here's what the academicians did on this study. They measured the skeletal width, not the dental, the skeletal width at the maxilla and the mandible at that first molar coronal site. Keep in mind, clinically, and this is how I was trained, when I do a clinical exam, if I'm looking at molars, maxillary narrowness meant crossbites. If there were not crossbites, I did not identify maxillary discrepancies, maxillary narrowness. I didn't see it. And on my study models, if there wasn't a crossbite, I didn't see it. Normal controls, no crossbites, and superior convergent cases look the same. They looked the same to me for the first 10 years of my career. I didn't see anything wrong with them. The roots and the axial inclination in the coronal slice are very important. And to me, the transverse dimension, since I've been in 3-dimensional orthodontics, the transverse dimension has become the most important dimension to me as an orthodontist. Here's what the study revealed. The normal controls, the maxillary skeleton on the lingual, was about 1 millimeter smaller than the mandible. That's the normal control. But look at the superior convergent cases. No crossbites. The skeletal discrepancy was greater than that of unilateral crossbites. And for most of us as orthodontists, we'd treat unilateral crossbites all day, but we'd leave the superior convergent alone. And this took a lot of retraining in our community for me to tell the pediatric dentists, don't just wait for a crossbite. Send me everyone at 7 and let me measure. Because we're going to find a lot of superior convergence. And this is the take-home message from the paper. Patients without crossbites can have significant discrepancies that might warrant treatment. And this happens a lot.